Everyone, good afternoon or good night, depending on where you are in the world today. Welcome back to our At Monty Heart conference series. I'm your moderator, Dr. Anna Bortnick from Montefiore Medical Center in New York. And I have Dr. Hayder Hashim, who is a cardiologist at MedStar Washington Hospital Center. Let me tell you a little bit about Dr. Hashim's background. He completed his residency in internal medicine at Rutgers University and then fellowship at Rutgers University for cardiology, and then interventional cardiology fellowship at Montefiore Medical Center, Albert Einstein College of Medicine. Importantly, Dr. Hashim has been recognized for his excellence in teaching with multiple teaching awards. I've counted about 9, and with the Arnold F. Gold Award for Humanism and Excellence in Teaching. And he also won Rookie of the Year in his first year out as an interventional cardiologist. Today, he's going to speak to us about the management of in-stent restenosis, the why and the how-to. And I'll let him give his presentation, and what we'll do is have some moderated discussion afterwards. So you can go ahead and put your questions and comments into the chat, and we'll bring those up as we go.
Thank you so much. Thank you, Dr. Bortnick, my attendings, my mentors. I'm full of gratitude this morning. Woke up this morning just remembering every single day, every single case with every single one of you in the lab. Learned a ton, forever grateful. You made me the interventionalist that I am on now. I'm by no means close to anywhere of completion or perfection. I'm learning every single day. I'm busy here in the lab. I enjoy teaching fellows. I remember how you guys put up with all our craziness, pushing the wire, dissecting some femorals, some radials, and making you change your plans. But I'm again forever thankful and grateful for every single minute I spend with you. I just named this presentation. It's a journey of how I got into ISR when I joined Washington Hospital Center, and how I slowly integrated new technology into understanding this disease entity. So I named it Management of ISR, the why and the how to. I'm going to show you. I have some, this is my conflict of interest. I consult and I speak for some companies. It's there for you. So I just wanted to start with the basics. So what's ISR? What do we know about ISR? So ISR, we still stuck to the same definition from many years ago, that ISR is a gradual re-narrowing or narrowing of a stent that we placed in a coronary artery, irrespective of the presentation, whether ACS or stable coronary artery disease. And for many years, we understood it as a new intimal tissue proliferation inside the stent. This could be hyperplasia, which is only tissue, and this could be hyperplasia that gets invaded by macrophages, and now you have something called neoatherosclerosis, which is a building plaque. Instead of de novo, you're going to build plaque in stent. And geographically, it's technically anything above 50% within the stented segment or 5 millimeters before or after. Clinically, it's exactly the same. You need to have an angiographic evidence, and then you have to add to it one of these things, at least one of these things. So it would be angina, you have objective signs, someone came in with acute coronary syndrome, elevated biomarkers, EKG changes, or you can do physiology or imaging into the stent. And if your MLA or your FFR is significant, or your resting index is significant, then you have a clinical ISR. So why does it happen? With bare metal stents, ignore this side, which is the thrombosis. This is a slide, it's an old slide, it's almost a decade old. Some of these things changed already, but simply you put a metal, you aggravate the lipid core in the media, you disrupt the intima, now you have exposed media into the bloodstream covered by a mesh of a stent, and then this can result in either thrombosis, which we treated very well by getting people to get antiplatelets, but also you can have a prolonged inflammatory response between all the macrophages, the giant cells that migrates to the stented area, and then slowly you create this hyperproflation or neoatherosclerosis or hyperplasia, and that's the bare metal stents. Then we get smarter. We said, you know what? Let's invent drug-eluting stents. So now I will have the stent that is a mesh but covered by a polymer, and that polymer can release a drug to suppress the migration and aggregation of the inflammatory cells. And hopefully this will prevent me from having stenosis. But then we start seeing signal of thrombosis, but we said, you know what? We saw thrombosis with bare metal stents, and we already decided on the antiplatelets. So let's not think about that. Let's think about restenosis only. In a general, in the contemporary era, generally, we will have DES from either drug resistance, very rare, that you will resist a chemotherapy in a nano doses, or hypersensitivity, which is something Dr. Bortnick and I, we worked on, and we've seen many examples in my training at least, of hypersensitivity. And most of the hypersensitivity we propose, or we thought, it is secondary to nickel allergy. We have many cases to demonstrate that. Now, nickel allergy will become an important part of my practice now, where I see a case of ISR. There is a screening form that I created in our lab to screen. It's a simple question. You ask the man or woman, do you have allergy wearing anything metal, a watch, a necklace, an earring? And they will tell you that I grew up wearing gold only because I always have skin breakdown. Is there a clinical link in outcomes between ISR and allergy to nickel? It's hard to believe yet, or it's hard for me to prove it yet, but it's work in progress, because this becomes an issue now with TAVR. Obviously, TAVR has more nickel than a stent, and it makes you wonder: is there a problem with patient mismatch or patient prosthesis mismatch, or if there's any problem with TAVR down the road in patients with nickel allergy? It's still just thought provocative, nothing proven. Now, mechanical factors is, we also realize that if you have an ununiform distribution of stent struts, which will lead to ununiform drug deposition, and you can have ISR. And this always happens if you land in calcium. If you land in a nodule, then your stent is crooked. Your drug is not infiltrating the calcium nodule back to the media to suppress the migration of inflammatory cells. That could lead to restenosis. Stent fracture, we know. And polymer peeling, I added this here in terms of polymer peeling, because we've been hearing about Europe using intravascular lithotripsy or shockwave balloons in treating ISR, while the engineers from Shockwave not recommending the use of IVL, and still an off-label use, and that's probably secondary to polymer peeling and exposing the stent, losing the drug that's in the polymer, leading to restenosis, and some technical factors, which is incomplete stent expansion. No one to blame but the operator for this one, because as an operator in 2021, you have to make sure that you leave the coronary artery with a full stent expansion. Stent gaps are geographic miss. For many years, we stented the areas where we see angiographically is the tightest, leaving an area behind. That area behind, as much as angiographically you think it's free of disease, we know that atherosclerosis and plaque process is a diffuse issue. So it's hard to nail down only a normal segment angiographically without using imaging. And obviously barotrauma, the higher you go trying to push a stent because you did not modify the plaque well, you will create more barotrauma at the edges. And this could be responsible for why we called ISR as a 5 millimeter proximal and distal to the stented area. This is Mehran classification from 1999. This classification is an angiographic base for bare metal stents. At that time, we didn't have, even if we had implanted some DES, we didn't have ISR yet and drug-eluting stents first generation. And simply, the way we define this angiographically is you have focal and diffuse. And if it's focal, middle of the stent, right at the edges, excuse me, middle, so this was, sorry, I apologize, I misspoke. This is the gap in between the two stents. This is at the edge. This is in the main body of the stent, or you have multifocal either on both edges of the stent or edge and a middle. Diffuse, you can have it all within the stent or within the stent and extends out, or it becomes so severe that you end up with a total occlusion, which is a CTO ISR. This is, again, angiographic based on bare metal stent data. Now, you're gonna tell me, you've been talking to us for the last 5 minutes. Yeah, we know ISR. Thank you very much. why this is, how common, why are you going crazy about this? I'm going to tell you why we're going crazy. So this is back again, all data. I'm just trying to build up the case here for my proposal. So the stress and Benny stent in 1994, they told us that we did very well by putting stents, if you compare to balloon angioplasty. So we got the minimal luminal diameter bigger. The stent is better looking, and geographically, we high-fived. We did a good job. We don't see these micro dissections. We covered. It's more uniform. But guess what? We still have angiographic restenosis of 30% and clinical restenosis in 6 months at 10%. So yes, so you might see the 50%, the 40%. This is why the percentage is high. But clinically, it's still 10%. People are coming back with bare metal ISR with a problem, clinical problem. This is contemporary data now. And then if you look at since 1998, bare metal stents, and then 2001, when we start putting the first generation and then into the second generation, we still, yes, we dropped the rate from 30%, but we still at 10%. In every single busy lab, 10% of your cases, look at your data, it will be ISR. Obviously, in a center like ours, where we do brachytherapy, that 10% is even higher because now we see radiation. Those cases are miserable. They're run out of options. They don't know what to do with them. The bypass graft is already down. The 2 layers of stents are already ahead of you. And now you end up with trying to fix it. Now, we also know from contemporary data that the smaller the stent, the worse ISR you have, something very common for interventionalists or anyone in the cath lab. And obviously MACE is worse for patients with ISR. You're going to say, yeah, show me evidence. So that's why this is why the presentation is now, okay, it's 10%. There is 90% we're making difference. We're still treating ACS, we're saving lives, we have shock patients, we have surgical turndown. So we provide good results and good options for patients that don't have any other options. Why bother with this 10%? I bother with the 10% because it's going up. This is NCDR. This is published in 2018, and you could see that the ISR cases are going up all across the board. And this is contemporary era. Don't worry about the graph now because I summarized the graph right here. This is comparing stents that we use on a daily basis or we used on a daily basis. And if I stented a de novo lesion with 1 layer of stents, there's a 2% increase or a 2% rate of TLR, target lesion revascularization, at 1 year, and that's only increasing. Now you have to understand, if I stented it, where is the problem? The problem is ISR. So your rate, putting a stent in a vessel, that's an everolimus covered stent, you will have 5 to 10% ISR or target lesion revascularization rate of 5 to 10% in 5 years. If I put a second layer, if I see this guy, oh, I stented you in 2015, oh, great, you 2020, life is good, let's do it. Here we go. I put another layer stent, guess what I did? I made your 10%, 33% in 5 years. It's even worse. And I'm stuck because I'm an institution that after second stent cannot do brachytherapy or doesn't have drug-coated balloon, or I'm seeing the patients over and over with a balloon after balloon, and I'm now, you know what? This is your 4th visit in 6 months. Let me do this. Let me add a 3rd layer stents. Look what I did. In 6 months, there is 25% failure rate. This is from multiple papers, all in the contemporary data. Now, you're going to say you're biased, Hashim. Oh, you've been talking to me. It's all everolimus. You put an everolimus graph. This is an all-comers, all stents. All comers. You could look at the fine prints. This is comparing. This is Resolute, the Medtronic stent. This is paclitaxel against everolimus. This is sirolimus, zithrolimus against everolimus. All these data telling you that there is rate of failure at 5 years, 13%, 19 to 12%. Yes, one stent is better. You can argue the data. I'm not arguing which stent is better here, but I'm just trying to tell you that with all across the board, any stents, multiple trials, you will have by 5 years, 1 in 7 patients will come back to you with target lesion failure or target vessel failure. Most likely, not most likely, it is commonly driven by ISR. This is not, again, this slides It does not, I'm not trying to tell you CABG is better than PCI. You can debate Excel for the longest. There are multiple sub-analyses and studies that came out of Excel, but I'm just trying to summarize to you that revascularization, whether following CABG or following PCI, it's bad. It is bad because if you have someone in a randomized trial and you did every single thing by the book because you are adjudicated by the committee, you put a stent. If that person come back and you put another stent or send them to CABG, you have a really bad mortality at 3 years, which is 12.9%. So those patients came in with PCI, randomized to PCI, you put stents, in 3 years, they have bad outcome at 12.9 mortality rate in 3 years. Same thing applies for CABG. Now, probably CABG mortality rate is better because most of the time, the lima is your safety line. You end up stenting the RCAs, you end up stenting the OMs because of a vein graft failure, but the lima is always helping you. That's why the mortality is a bit better if you do revascularization after CABG, but it's still 7.6. That's my explanation. Now, same exact thing if I do successful ISR. So now, you after my this spiel, you're gonna say, you know what? Hashim told me all about ISR. I'm it. I'm the ISR guy in my institution. Guess what? I'm the ISR in my institution, and I will have 15% failure rate from ISR PCI. You can name yourself anything. You do the best job you can. You still carry 15% at the first year target vessel failure for what you claim successful ISR PCI, which is a second stent, brachytherapy, whatever you want to call it. You will have a problem. This is just recent, 2020. This is from COVID, when we sat down and we didn't know what to do. We don't have patients, we wrote papers. That's what we did. We looked at 19 meta-analyses. We all looked at those patients. We still have the 2% failure rate still exists 1 to 5 years after any stent we place. So as much as we think we change polymers, we change stents, we change thin struts, nano-coated, no more bare metal, let's bring back bioabsorbable, we're doing a good job. Again, I don't want to bash my passion. I love what I'm doing, but there is still that 2% of stent failure in 1 to 5 years. That's still across the board, despite the fact we are 90 prospective randomized trials, not for ISR, but for anything else, we still have this rate. So there's something we're missing. There's, as much as we think we did a great job inventing DS, there's something missing. So what are we missing? That was my mission when I joined. I joined MedStar. It's an imaging heavy lab. There is a fund of intravascular imaging data, and it's a brachytherapy lab that attracted most of the, if not all of the local and regional ISR cases because of the need for radiation. So what are we missing? Why we changed DES? We made it thin. We made it the polymer. It's abluminal. It's not on the lumen size. We did all these changes, but we missed something. And I think what we missed is the underutilization of intravascular imaging. That is my passion growing in this field. I want to really utilize, I want to make 2021 or moving forward this decade, angiography guided PCI should be a part of history that we talk about, just like when we remember the days when we have infusion balloons, which I've never witnessed, or the Palmat stents that you mount on a balloon. I never witnessed. I do some of them now when I do some aortic work, but I've never witnessed that. I don't know how people did it. I don't know how people did cut down. Same thing, my vision as I'm growing older here, I want to see that the time when we did angiography PCI, it's gone. It's all intravascular guided. This is probably the piece that we missed in all trials that led to the approval of the stent and documented ISR and thrombosis, because I believe we did not good job. We're not doing a good job treating ISR. I have 15% failure rate in the first year. And then I think we are lacking the understanding of the de novo lesion before I put my first stents, because I do believe the best way to prevent ISR is not to have a stent, or if I put a stent, I need to optimize it to the best of my capacity. And then am I understanding ISR well? Do I know why the stent failed? Because if I correct that, my second stent inside my old stent should be better looking and have better outcomes. This is a Korean single center, because we always say, oh, Korean, Japanese, they use a lot of imaging. They still don't use much imaging. This is 6,000 patients. They have this 80% of their ISR cases were angiography based. They used Mehran classification. They looked, oh, it's focal, it's in the gap, cover it, balloon, put a stent and come out. They used imaging in only 21% of cases. Then we said, how about this? Forget Korea. Let's talk about the US. This is my data. This is our data. This is a case. This is our publication. We looked at our data. This is we're looking back from 2003 to 2016. We used imaging in 67.3%. And we didn't use it in 32.7%. Good. This is for complex. We picked type C lesions, which includes CTO, bifurcations, left main. You see all the long lesion. We use the definition that everyone agrees that it's a type C, and this is what we used. IVUS in 2/3 of the cases. There was always benefit in MACE for IVUS guided PCI, and even if I do an inverse probability weight, which I take every single one of those categories on its own, there is still benefit for IVUS. Now, obviously, this is a lab that I have. When I want to use IVUS, we have a senior technologist in the lab that will come to the lab, do the IVUS for me. I don't even take my gloves off. I have on my screen, I project IVUS, I project OCT, and there is a senior technologist in the lab that day doing nothing but IVUS, but imaging. They will walk, they will tell you, I can disagree with them or agree with them, but they take that headache and they built a major database. So yes, the data is biased because this is a single center in a heavily intravascular image lab, but there is a signal. And then ultimate comes out. And ultimate, yes, another argument. I'm not here to discuss the trial itself, but that's another signal that there is patients in Japan, when you are capable of doing IVUS, you will have better outcome putting a stent using IVUS or intravascular imaging compared to angiography guided PCI. So we have the signal. What do we need? This is our proposal. We felt that the era of BMS is gone, that ISR classification based on angiography only, it's part of history. And intravascular imaging is a cornerstone in understanding why my drug-eluting stent failed. I need to understand how many layers, because that will change my treatment, which will lead me to the second point, which is tailor my treatment accordingly, because not every single ISR needs to be treated by another layer of stent. And then can I make sure that even when I put the second stent, can I make that 15% in first year better? That came out with our proposal. This is the journey. The journey now, we felt that in a contemporary time, in a time when we have the capacity to do intravascular imaging, IVUS or OCT, or IVUS NIRS, which we should reclassify ISR and drug-eluting stents based on something else, based on imaging, based on the mechanism of failure of that stent, because we believe that will change the treatment. And that's what we proposed and published in 2019. This algorithm we have, it's in the lab. It's laminated, stuck on the wall. And you could see the first step. You see an ISR, or I get a referral for ISR. This is my step. I don't look further. The minute I see ISR, it's time for intravascular imaging. You could use anything you like. I favor OCT. I do believe that OCT has a superiority for checking, for defining ISR better than IVUS, and I'll show some examples now, which is a publication in press now that's going to come out. I'm going to show you the figures we have, but I do believe OCT is superior in ISR. However, there are limitations to OCT, but there are multiple techniques that we are doing now, pioneered by Ziad Ali, by other imaging interventionalists, on how to do OCT utilizing less contrast, utilizing saline. For osteal lesions, we're using guide extensions. But again, I stop before I look at anything. Guide in, diagnostic catheter in. I see ISR. The next step is imaging catheter on the table. Then I will define what's happening with my stents, whether it's a mechanical issue that I will treat differently, because mechanical needs to be treated mechanically. Biological, I might use something else. I might have mixed. I might have a mechanical problem that slowly led to a biological failure. I know how to treat that if I had defined which problem is there. I have CTO. Now, obviously, CTO cases is never ad hoc. I'm not telling you to do ad hoc, but even with CTO, when we cross an ISR CTO, we pause and we do imaging and we reinvigorate the case as if it's a new ISR with an established lumen. Or if I have a 2-layer, then I'm really handcuffed and I don't have many options. But still, as an institution here where we have brachytherapy, that could be an option. I'm going to take you through every single subdivision with imaging examples. So this is a case of underexpansion. It's underexpansion. This is the stent. This is the media. We all know on IVUS, the media is that rubber echo lucent area, which consists of the internal elastic lamina or membrane with an external elastic membrane. And you could see that the stent is underexpanded. Now, there's not much ISR there yet on IVUS, but this, you cannot walk away from this. And I could almost bet you that this will look perfect on angiography. But you undersized your stent and you didn't push this stent and the plaque all the way back to the media, which is the actual vessel size. You know where the problem is? On this OCT. This OCT now, there's a single layer of healing, not much ISR. It's tight because this is the lumen is tight if we have measured it. But I'm trying to show you what happened here. What happened here, that there was a stent out here and there is a neoatherosclerosis with calcium inside the old stent, which was probably a first generation. And what do? We add another layer of stent without treating the underlying. So now I ended up with an underexpanded stent, second layer of stent, and an old stent. There is nothing worse than a first layer underexpanded stent, except for a second layer inside an ISR, which is still underexpanded. Miserable, defining miserable. When I go home after a case like this, no dinner, no breakfast the next morning. I might take a day off too, because I'm miserable. I'm teasing. But now we get to stent fracture. Now, when stent fracture happens, it usually happens in a hinge point in an artery, and that's usually when the RCA leaves the AV groove, when you start having the distal RCA and the PDAPLV branches, or it's in the circ when it's taking a bend from the left main. And osteal circs, one of the lesions that always win against you. If you stent an osteal circ, anticipate a lost battle, just like a vein graft. We do it, but we could because we are forced to do it in certain cases. But that hinge point, when the first OM wants to come out of the circ, that hinge point, if there is a nodule, which is most likely there is a nodule, we've all been through those miserable cases with guide extension, can't deliver anything in that circ, that's when the stent fracture. I don't know if it's projecting well, but if you look right here, there is that small stent that fractured, and that was a nodule. How do I know there was a nodule? Because this is the nodule. It's in my face. This is OCT, full of goo. I couldn't get anything through. This was an OCT after laser. I'm lasering this. This is what laser does to your hyperplasia. This was a mix. This was a stent fracture that created hyperplasia that I needed to evaporate using laser, just to get the OCT camera and understand what happened. Now, how do I treat this? If it's underexpanded, high pressure balloon, hopefully that will open back up if you have fibrous tissue behind it. High pressure balloon works for underexpanded stent freshly implanted. Laser, there is some data, not robust, but there is data, and we have nothing else approved. Intravascular lithotripsy or orbital and rotational atherectomy, they are off-label use. You have to remember, have we done it? Yes, I've done it. In what sense? Certain people say if you do rotational orbital inside a stent, you create enough heat that you can make the stent more malleable and more pliable for you to push, and hopefully that heat creates some micro bubbles, just like laser, that will fracture or cut through the fibrous bands connecting the calcium. Europe is definitely, have I done intravascular lithotripsy and ISR? Yes, I've done. When I'm forced to do it, when I do imaging and I see a big nodule, I've done it. It's off-label use. I'm not recommending that. There is no data, and I don't think even Shockwave is pursuing that line in terms of using IVL. Is there a room? Do we need to prove it? Yes, probably. Very intriguing thought. Now, when a stent fracture, you have nothing left. You open, and then you put another layer of stents in the hope that a second layer of metal should enforce and fight against your stent fracture. I'm not going to bore you with this. Very minimal. Even with the approved laser, there is minimal data, small, tiny data telling us that there is better lumen, there is better intimal hyperplasia, cross-sectional areas, small sample size. But guess what? We're desperate. We have to use it. No other choice. Can I use it with contrast? Yeah, but this is, again, contrast and laser, it's an off-label use. It comes with a long barrage of side effect adverse event during the case. Have I done it? Yes. Have I modified the way I do it? Yes, I modified. I use peripheral catheter, which is over the wire. And because it's over the wire, at the end of the catheter, I put a copilot, and through the copilot, I take my workhorse wire through the Y connector, I put a deflator, and I put I put contrast along the wire inside the microcatheter, which is the laser, and then I will just drip at the front. This minimizes injection of laser in the guide. It's yet to be proven. It's a paper that I'm writing on the technique, but that's what we've done this. I've done this with Nelson Bernardo, with Rob Galino and the legs. They pioneered this way before I did, and we're just using it for the coronary, but off-label, nothing. And whenever you hear off-label, you could sense the feeling of desperation. ISR is a desperate problem. It's an issue that we need to fix. Rotational atherectomy, yes, done, but still carry a high risk of target lesion revascularization. There's a problem. Even when we use it, again, 20 patients, we can't even enroll patients because it's off-label use. This is all registry data. Biologic, that's the second step, move you away from mechanical. Neointimal hyperplasia, most common type. It's homogeneous on OCT. It's homogeneous echogenic on IVUS. Neoathro, it's different without calcium. If you look at IVUS, there's not much difference, my friends. It's almost the same. I could see tissue. You cannot deny it. But it's not telling you homogeneous versus heterogeneous. Here you're almost having a new this is a thickened intima fibrous cap, and this is lipid. How do I know it's lipid? Because it's homogeneous. It is high attenuation. I cannot see the stent behind it. So this is lipid core invading the intimal hyperplasia because this stent is 5, 7, 10 years old. Now I'm having now I have neoatherosclerosis inside this. So now it's neoathero with calcium. How do I see calcium here? It is, it's bright, and it drops the signal behind it, which means it's deep. If it doesn't drop the signal behind it, you see reverberations, then it's superficial calcium. Here on OCT, clear cut, thick fibrous cap, and an ISR, which is neoatherosclerosis, and all this well demarcated layer, it's calcium. 360 of calcium of different length inside an old stent. This is an old Cypher stent from 2004. 15. This is one of my cases, 15 years after. How do I treat? Again, if hyperplasia only, I will do balloon. I probably time for scoring, for cutting, to create a fenestration, make sure that the tissue is pliable, and you put a stent. Or you can use brachytherapy, even if it's first layer of stents. We've done it. We have our data. We will share it one day with you. Good outcome. Especially if the stent lumen is small, there's no enough, even if it's a single layer, just do brachytherapy. Same thing for if it's neoatherosclerosis without calcium, you do the same, you put another layer of stents. You just need to treat the neoatherosclerosis as if you're treating your de novo. Whatever you're using, it doesn't matter to me. Rotational atherectomy, it's a nodule. Orbital atherectomy, you want to use DCB if you're in Europe, go ahead. Make sure you treat the ISR before you put another stent. Few pearls on brachytherapy. This is a brachytherapy. This is 6 months after brachytherapy of intimal hyperplasia. Do you see the vacuoles? This is what radiation does to the tissue to control tissue apoptosis. You create these vacuoles and this tissue becomes friable. You can just scoop it with your finger if you want to. This is from our database. Now, obviously, if you use brachytherapy, few things you need to know. The duration, even if you don't put a new stent, you need to go 12 months. If you did a case like this and you ended up needing another stent, if you put that stent in, you are forever on DAP, because that hyperplasia, this lesion, it's very thrombogenic when you put a new stent. Obviously, do not combine it with a newly fresh placed stent, because you want the inflammatory cells, but now you're suppressing it and you have a drug. It's a long story. You can review brachytherapy data. This is not the scope of this. Mixed, obviously, now I have an underexpanded stent and I put a stent and now I have 2 layers and now I have more of ISR. Same thing here. Miserable, 2 layers, underexpanded, mixed, it's not good. Treated the way you like, using the same treatment options for biological and for mechanical. CTO, another one. This is 2 layers, CTO ISR. Guess what? If I open it, this is what I end up with. This is how CTO, this is data. CTO and de novo, it's not the best. Guess what? CTO and an ISR, it's way from best. We're not doing anything. You almost want to, increase Renexa and Imdor. But sometimes I do CTOs on Wednesdays, so it's indicated in certain cases. It's just case selection. 2 layers of stents. By this time, you're very limited. You either keep ballooning as much as you want. You either do DCB, hopefully nothing grow again, or use brachytherapy, and then last resort, you send cabbage or redo cabbage. So I'll take you with a quick atlas of few cases, and I'm almost done to allow some questions, just for you to see the different types of OCT, because this is the segue for my next 5 slides, which are the last 5 slides. Neointimal hyperplasia, homogeneous. This is calcified neoatherosclerosis. This is a very well demarcated tissue inside an old stent. So you're going to ask me, Hashim, you just defied yourself. This is the media. Everyone agrees this stent is well expanded. So how come you have this? Well, this is part of accelerated plaque formation, neoatherosclerosis, in the first generation or bare metal stents. You can have calcified lesions inside stents as ISR, even if the stent was well implanted, because that's the lifespan of the stent. What is this? This is heavily lipid. There is a stent here, believe it or not, but this is heavy lipid core that is almost the sand washing of the shore appearance, because it's heavily attenuating. It's not letting the light goes through. This is stent underexpanded right here with tissue inside of it. Now, why this is important? Because you will face this. If you have that neoatherosclerosis with lipid only and a thin fibrous cap, you know what you're going to have? You're going to have this guy. You're going to have disruption of that intima, spillage of lipid, and you will have ACS and ISR. So ISR, it's not indwelling angina that is, you keep giving Imdor, Renexa, beta blockers. No, they could rupture the plaque and they present to you as ACS. So you need to understand with imaging why ISR happened, because here, I'm not advocating brachytherapy in the middle of the night. You have a ruptured plaque, you have core coming from neoatherosclerosis ISR, put a stent and exit. Here are other cases. I require to do atherectomy for this, to shave this off and put a new stent. This is calcium, sorry. So remember your tools, but please do not use any of these tools without understanding why are you using it. And the only way to understand why, it's not angiography, it's intravascular imaging, preferably OCT. This is take-home messages, whatever I just said. And here we go. This is the introduction to the next 3 slides. Over the course of the last year, utilizing my database on OCT, I was able to put an app. By no means it's an app to recommend what to do. It's an app, an educational app. It's an atlas of all ISR in OCT, and it's also some OCT pictures on the treatment options. So when I recommended to you orbital atherectomy and ISR, I wanted to show you what that does in a picture. I'm not telling you open the app and say, oh, I see this, let me do this technique. Do the technique that you're comfortable with. Call a colleague. This is, again, it's an atlas, it's an illustration of types of ISR and types of treatment and how they look on OCT. It's available on Apple, on Android. It's a very simple app. There's nothing much. These are the classifications that we have. You click on it, it will take you to the subcategory, and then you can see a picture. And you see the picture with a small blurb on describing what's there. You can enlarge the picture by clicking this, and now you could see it in your entire phone, and all the text is here in this pull-up list. You can save it. If you click on this, you could have annotation if I'm describing to you a certain pathology. And obviously, when you pull this up, you see the source where the images were taken from, what time is uploaded to the app. Again, it's an atlas. The beauty of this, my vision, when I did this, when I'm on Twitter and I see all these beautiful cases people doing, sometimes I want to have this small society of ISR imaging guys or operators. You can submit your image, and the image will come to an email, and there's a small committee of few of my friends that will review the image, and then they will push the image to the app based on what do you think. You will write your own caption, you will write your own overview, you want to tell me your notable issue, do so. This will count as I hate to say it, peer review publication, but again, it's peers reviewed your image, and instead of having it on Twitter, you can have it on Twitter, but you can push it to the app and create this big database of how OCT can help in ISR. It's there. These are the QR codes, and that's the end of my presentation. Open to any questions. Happy to answer as much as I know.
That was outstanding. Congratulations on that wonderful tool that you're building and crowdsourcing to get an educational resource for everybody. I want to go into the chat for a moment. There's a question that popped up early on when you were talking about one of the the first classification or the new classification of in-stent restenosis. You were talking about mechanical in-stent restenosis. And the question in the chat was, how is that different, or how does that look different from late malapposition? Can you tell the difference, and does it matter?
Sure. So data is very clear on malapposition versus under expansion. Malapposition, especially at the proximal segment of. So I'm going to give you a scenario. I did a stent in an LAD, and then I exited, and I didn't do imaging, or if I did imaging, I didn't fully oppose the proximal portion of the stent. I'm just going to make the life of the second intervention, the next interventionalist, miserable, because their wire will go behind my stent. Is it associated with acute thrombosis? Yes, probably, because of the eddy currents. That's why we recommend, if you see a proximal edge malapposition, push it with a semi-compliant balloon, not a non-compliant balloon. You don't need pressure. You need size growth. Just push it. Don't overdo it. Don't dissect the proximal edge. Now, is malapposition related to ISR? No, it's not. Under expansion is. And under expansion is undersizing. That's what I mean. And sometimes undersizing is an operator mistakes because I didn't size my stent correctly based on imaging, or it's a morphology or plaque problem. It is so constrictive that even if you put a 3O stent, but you haven't treated the lesion well, you won't be able to put a 3O stent in a 2.5 calcified lesion. So under expansion is the problem. Was the difference between mechanical and malapposition two different issues? Mechanical, you're going to see a waste in a stent, you're going to see tissue in a stent. You need to image it to understand, is it compressed from the outside, or you just put a small stent in a big fibrous plaque?
Okay, so the second question has to do with kind of progress in the field, because clearly what you're doing today is not what you were doing 5 years ago. And we're moving on with drug-coated balloon trials in the United States. And the question is, what do you predict in terms of the role of drug-coated balloon? Do you think that this will replace brachytherapy? and maybe take over?
Yeah. So it's a major challenge because I think DES, putting a stent for ISR, still carries the strongest data, believe it or not, even with 15% failure rate. Stent and ISR, it's strong. DCB might compete with DES. Would it replace brachytherapy? Highly doubt. Based on we're writing a review, trying to do a propensity match between Europe data and our brachytherapy data, especially for 2 layers of stent. Brachytherapy is still scoring higher, believe it or not. And brachytherapy is a simple procedure. The catheter is beta radiation. It's a small catheter. It's hard to have the logistic around it, but the procedure itself, you could be blindfolded, halfway drunk, and you could do the procedure. It is a small, it's almost like an IVUS catheter, a short rail, a short monorail, goes in. You have 2 dots. You have 40 millimeters and 60 millimeter length, and you have doses, 23 grays or 25. That's all you have. You wait for 5 minutes. You deploy your radiation. You pull the seeds back. You need oncology, so it's easy. Now you might argue, you said, Hashim, you're nuts. You're going to use DCB. It's a balloon. Yeah, but it has some preparations. You send the balloon in. Which drug is better? So it's still growing. It might replace brachytherapy 10, 15 years from now, but in its own generation now, whatever has been used, I don't think it will replace brachytherapy. Personal opinion, based on no data.
So maybe what we can do right now is a little bit more of a thought experiment, but we work hard to avoid this situation by prepping the lesion as best we can. But there are some branches that we can't image well. They're too distal or they're small, and we get surprised and we end up with underexpanded stents in the moment, and we recognize that that's a problem. So what's your approach, when you recognize that you've underexpanded something? How would you approach that? And what are you going to do then? Do you surveil those patients differently, knowing that they may come back? How do you deal with that kind of moment where you say, that didn't look quite as I would have liked it leaving the room?
True. So Dr. Bortnick, I'll summarize. Your question is, I put a stent acutely, and then my next angio, oh, gee, what did I do? Okay, I get it. So our approach, we've done between Dr. Itzik Bendor and myself and other of my partners, we've done, sometimes you are forced to do so by putting a stent and we laser it right away. Like certain cases, there's a major dissection that happened because of a nodule, and you just want to seal it because you're losing the entire artery, and you haven't established full expansion of your balloon. I can get a stent through. Once I'm stented, I can use laser with contrast safely, because laser with contrast in de novo creates havoc. In ISR, in stent, it's more protective, especially if you just seal the dissection. What are you going to do? Dissect the artery? You just put a stent. So certain cases where there's an acute loss of the artery, I will bite the bullet and put an underexpanded stent as a strategy and do laser. If I under-recognized a branch or a small nodule that on my areocranial was looking good, but on my areocaudal didn't look good, there's a small divot, then I will laser it. And if not, I will keep pushing with non-compliant balloon. Why do I do so? Because we got many referrals that stents were placed in a different place without atherectomy backup. They will come here and we'll treat them this way to prevent stent thrombosis. An acute underexpanded stent is a nidus, and it's a precursor for almost happening thrombosis. Unless it's narrowed, but the MSA is still around 4-ish. Obviously recommended is 5.4 in Illumin 4, and also in our trial, improved trial that is ongoing now, it's 5.4. That's what we're using for MSA, for minimal stented area. But if you get 4.0, 4.5, yes, it looks underexpanded, but probably is not going to be a source of a problem. I will keep an eye on those patients. Tell them if you feel anything, come back.
A question about the laser. Do you find a difference between this is just a follow-up to this.
Sure.
Do you find any difference between the smaller versus the larger catheter? Do you think the larger catheter provides more energy or is a better device than the smaller one?
Yeah. So the 0.9, there are two. So there's rapid exchange coronary, and there's over the wire peripheral. The over the wire is a bit bulkier. That's number one. And number two, it's not recommended to use laser over hydrophilic jacketed wire because you might dissolve or melt and you get the catheter stuck, and you need to take everything out and lose wire and catheter. It's definitely stronger to use bigger catheters. So the 1.4, the 2.0, the 2.3 have higher energy. Another tip, obviously the big machine now is being replaced by a medium-sized machine, which is touch screen. And this is the Philips Spectralynx, Spectronics before. So what they have now is a smaller machine. If you use coronary, you get time out, and you have to wait and then restart again. There's a way to kind of overpass that. When I use peripheral, it allows me to step on the pedal and then for the longest I want. You don't need to overpass. The machine doesn't stop you to reset. With coronary, it will stop you every 10 seconds. It doesn't allow you to do so. You have to 10 seconds wait and do it again, using the same concept of orbital or rotational atherectomy. But in stent, I always use peripheral. High energy, I can buzz through. Off-label, please don't do it if you're not comfortable with laser.
So question about bioabsorbable polymers. Is there a difference of using something like the Synergy that you've come across in reducing ISR, or are all these DESs behaving the same way?
It's almost behaving the same way. Now, if you look at the FDA, the data that led to approval of Synergy, Xience, Onyx, Biotronic in the FDA, imaging was not a mandate. That was my message building the case. If we do a post marketing registry and we're trying to track ISR in these stents or stent failure, we don't mandate or standardize the technique to put the stent in. We give it to all institutions, enroll, put patients, and let us know. Who knows what Bortnick's style is from my style? Did she use OCT and I went by angiography on an old GE machine? I don't know. If I have stent boost, thank goodness. Some people don't have stent boost. So how do you blame a stent or a technology in a stent without standardizing the technique to put the stent in? We mandate this in all trials except when we approve stents. So yes, probably Synergy is much better than anyone else if they have mandated imaging. Probably Xience is better than this abdominal thing. I don't know. Ultra thin? I don't know. Same thing. Now yesterday I used a nano coat, the Cobra stent. So the nano coat is a bare metal with polished drug without the polymer. So it prevents acute stent thrombosis. That's number one. And then it will become a bare metal, so it minimizes your DAPT. I kind of took my bare metal stents into Cobra, a bit second step. But I don't know what's the ISR there, because if I put it without imaging, good luck.
That's a fabulous piece of advice and a good observation that maybe the trialing and the technique needs to change. And there's been a very low uptake of imaging, and part of that has to do with reimbursement in the private practice scenario. But let's talk about bifurcations. There's a question about treating bifurcation in stent restenosis. Do you approach that differently? What do you do when you've already had a layer of stent, someone's done a bifurcation?
Yeah.
They did a crush, you have maybe 2 layers already in your location.
So I'm too young in this arena. And I've done few DK crushes in left main by the textbook. Like we open the textbook, the fellow and I, and we go, do this. Okay, we did it, check. Truly, with imaging in every single step. I have 3 cases. It's published. It's on CRM. You can. I wrote it. All of them came back within 6 months of ISR. I don't want to call the osteal circ freaking osteal circ, but it is a notorious area to put stents, and worse, to put double layer stent with whether culotte, DK crush. It's horrendous, because next step, when those patients come to me, I did Impella, I did it all. DK crush, took my time, atherectomy, this, atherectomy, I did it all. Came back with ISR. I'm stuck now. Both limb ISR with the main stem. So that Y bifurcation, it's gone. What do I do? The only way to come out is DCB, because I can DCB LAD left main, I can DCB circ left main. When I did it, I did brachytherapy. When you do brachytherapy, you cannot brachytherapy both branches. It's too high of a dose. It's not recommended. So I ended up picking the LAD, and I was hoping that it's a crazy idea. Hopefully, some of the radiation will ooze into the circ. It's not going to ooze. It's not water. It's radiation. So I ballooned the circ, the limb, circ limb, and I VBT the LAD. Crazy. Again, if you want to avoid bifurcation stenting by all means. I beg. Osteal circ, there is no such a thing. I nailed the ostium, the circ of the ostium. Yet to see it. Always go back to the left main. That's my practice. I changed my practice. It's published. I'm not ashamed of it. Is the end of the day, it's patient outcome, because that patient could be my father. This is exact. I really hate doing DK crush or culotte and bifurcations anymore.
Somebody wrote hashtag facts.
Oh.
Yeah, I think you're expressing probably a common experience, common frustration. And if you're doing that kind of bifurcation stenting, you're talking about somebody who's probably inoperable or who has already been operated on, and this is their last resort. So
exactly,
the buck stops with us often. Okay, so let's talk about shockwave for a moment. Intravascular lithotripsy, new technique in the United States, and using that in the setting of in-stent restenosis. Someone wants you to discuss the pros and cons there.
Cool. So we were part of Disrupt CAD3. I probably did 23 of the cases in our institution, and that's this is the trial that approved feasibility and safety and efficacy of the balloon, and led to the FDA approval. We were part of it, but that was de novo calcified lesions. In ISR, there's much data. Probably Dr. Latif can comment even more, knowing he was trained, has huge experience in Europe. They've been using it for ISR. Here, as I put in my slides, it's off-label, and the main driving force is the polymer peeling reported to us by engineers from Shockwave, that there is damage created to the polymer from the lithotripsy. So that's a con. Now, obviously, probably I can argue with engineers, not that I smarter than they are, but probably that stands well for an acutely underexpanded stent, something that we discussed. If I probably shockwave a polymer, then I will probably peel it and render the stent bare metal acutely, which makes it a bare metal. You have ISR. But what if I get a case with neoatherosclerosis ISR and calcium? Can I fracture that calcium? The polymer is gone. What polymer? The polymer is already squished by calcium. Can I use shockwave? Is there differentiation there? Yet to be proven. Probably if we can get some European friends to give us a sub-study on neoatherosclerosis with IVL versus hyperplasia with IVL, probably there is a difference. I don't know. From a technical standpoint, the shockwave balloon comes in 2.5 to 4.0 and a 12 millimeter length. That's the only thing we have on the coronary. We have longer and bigger sizes from below knee peripheral, but that's 40 millimeter. So certain cases with ISR, delivery of the balloon is going to be hard. But at the end of the day, if you're committed to do something, you'll deliver it. You put a guide extension, body wire, put a mailman, wiggle, your choice, and deliver the balloon. Have I done it? In desperate measures. When I have a bigger lumen, bigger ISR lumen, but I'm still not fully expanded, I can't do orbital atherectomy. If I want to do rotational atherectomy, the biggest I have is a 2.3 that goes in a 10 French. So then I'm stuck with using a 3.5 or a 4.0 peripheral before we have this, and then use it off label. Do I have cases? Yeah, of course. I have, between Nelson Bernardo, myself, Itzig, yeah, we probably have 5-6 cases in the United States where we use shockwave for ISR. Have they came back yet? Not yet. I don't know. They might come back.
Keep them on your radar. So last question for you. What about intravascular lithotripsy without stent? Is that possible? Is that recommended, not recommended? Any information?
I really don't know. I don't want to commit to an answer. Just by thinking about it, I don't think it's recommended for de novo. You mean de novo or ISR we talking?
Just de novo. Could you
De
just?
novo, I'm not sure, Dr. Vortnick. I think the amount of inflammation, the deep media disruption that you create I think you need something to suppress inflammation. Probably the more intriguing is an osteal circ with a nodule. You put shockwave and DCB. Great trial to do. Probably that will solve my nightmare, which is the osteal circ.
Right. Or maybe we should look at that for other lesions as well, right?
Exactly.
Maybe it's a way to remove the stent from some of that, although there's going to be some recoil. So the recoil you treat with the stenting.
I hope DCB gain more traction, because if you just close your eyes now and imagine you are on the Caribbean and remember the last few cabbages referral you sent. Not most of them, there's a big portion of them, they were sent because there is a bifurcation RPDA to PLV. The RCA looks gorgeous. It's a 4O vessel, but right at the crux, there's a problem. Or it's a PDA, or it's an osteal OM into the circ. And you go, you know what? If I put a stent, I will jeopardize my main branch. If DCB works for those, probably their syntax score will be less. And you don't send them to cabbage. I hope I'm still alive when that DCB day comes, that you can use it in these small branches and proven to have good efficacy and patency rate. Without ISR, don't put a 2.5 stent and bifurcation PDA PLV, do DCB. And
Right.
fix the Proxel AD with a stent, with a 4.5 vessel, 4.5 stent, because it's never 2.5 in a Proxel AD. It's almost never 3.0 in the Proxel AD on imaging.
All right, so we're going to stop here. We're out of time for today, but that was a fantastic session on ISR, the how and the why. And we can catch this on YouTube on the link that Milagros Autono is putting together for us. I want to thank her for her expertise in coordinating this whole conversation and discussion that we have with the At Monty Heart lecture series. Thank you, Dr. Hashim. Have a really productive day, everyone. And good morning, good afternoon, and good night to everyone, wherever you are in the world.
And please, hi to everyone. I miss you guys. I'll visit, I promise.
We miss you too.
Thank you for the invitation. Everyone.